This is the fourth panel, the after lunch panel. So when Colleen first asked me to chair this panel, I said, sure, how hard could it be? It's not like it's brain surgery. And then it is. So we're talking about neurotechnologies on this panel. And I think when we're thinking about things like privacy and security, there's nothing much more private than what's in our brain. And we can also think about how the brain is so influential on identity and how we understand the world. And in many cases, when we start thinking about issues about consent and the possibility of people being in mental states where they're not able to give consent, or it's not clear whether or not they're able to give consent or properly understand situations, there's a whole host of really interesting and difficult ethical questions that are raised when we start talking about neuroscience. There's also social questions raised. We've already seen the widespread use of at-home EEG systems for meditation and games and even flying little drones. People are experimenting at home with deep brain stimulations and things like that. And we even have more extreme forms. There was a neurologist, Phil Kennedy, who went to Mexico to get neurological implants into his brain and almost lost his mind in the process. And a whole history of this sort of activity of interfering with the brain. There's a great documentary called The Lobotomist from PBS around 2008 that looks at Walter Freeman and his work in lobotomy, which was scary, to say the least. And so we have here today a very prestigious group of lawyer and brain scientists. We have Jennifer Chandler, professor of law at the Center of Health Law, Policy, and Ethics here at the University of Ottawa. We have Tiago Mestre, neurologist at the Ottawa Hospital and associate scientist at the Ottawa Hospital Research Institute. And we also have Sachs, who is the director of Neuromodulation and functional neurosurgery at the Ottawa Hospital, as well as an associate scientist at the Ottawa Hospital Research Institute. You can read more about it in their bios, but I want to turn it over now to Jennifer, who's going to tell us about neurosurgery and the law.
Hello. Hello, hello. Thank you very, very much. Thank you, Colleen, for this excellent opportunity. Thanks to my colleagues for being here. I think you will have noticed from this topic that we're looking at one sector. A lot of the discussion so far has been of critical cross-sectoral issues, whether it's equity, discrimination, safety, regulation in general. So this is a little bit different. We're going to take the opportunity to look at a case study, in particular AI and neuro and the brain, to see about excavating some of these particular cross-cutting issues that we've talked about earlier. And I want to make the case to you that when we think about AI and the brain, it's a justified case study, and it might bring something a little bit different. And that is that we've been talking a lot about data that's out there and AI's role in its collection, its interpretation. These things affect our thinking, our decision-making indirectly. The AI will affect our thinking indirectly. Right now, we're talking about technologies that will affect our thinking directly. So to the extent that AI is contributing directly to the contents of your thoughts and your decisions and your behavior, this arguably, I think, raises some issues that present themselves in a different way, especially around vulnerability. And to get to the point of my talk will be a sort of a hopefully not too meandering route to bring you to the argument I'd like to make, which is that at a legal, ethical, perhaps metaphysical level, we need to think about vulnerability a little bit differently as a result of the inclusion of AI in these neurotechnologies, neuroprostheses. So let me start then. So first of all, this whole area of manipulating the brain is not new. We've been doing it for at least 8,000 years. There's skulls with holes in them, which were, it's hard to know, there's no documentary record, but it was likely to have something to do with behavior and concern about mental illness and neurological condition at the time. We've also been using electricity in neuromodulation for at least 2,000 years. Galen talks about it. Electrical eels and rays were good for headache and so forth. But this is a story of continuous technological evolution. So if we skip a couple thousand years, we can come up to the mid-20th century, and we have surgeries like the lobotomy that Peter mentioned. We had ECT coming in the 1930s as well. And then in another and later wave, we have more sophisticated, more targeted forms of similar treatment. We have deep brain stimulation. We have new ways of inducing lesions in the brain as well, ablative surgeries. There's also exciting new forms of non-invasive brain stimulation for superficial stimulation as well as deep stimulation of deep structures within the brain that are being developed. Sort of every time you look at the literature, there's some new interesting idea. And I think the next wave here is going to be, and it's not, I didn't make this up, I read it in this last 4 months of literature, is an increased focus on the incorporation of AI in brain stimulation. And here's where I suggest we have a new need for a new understanding of vulnerability, which in turn will cause us to rethink our legal approach to consent and to regulation of these treatments. So I'm going to tell you a story about deep brain stimulation and its evolution. So we started in the 1990s with deep brain stimulation for movement disorders like Parkinson's. Now what this involves is an electrode into the brain to stimulate a targeted piece of the brain, sort of an on-off kind of thing that can be sort of titrated within sort of set parameters for individual patients to control symptoms. So that's been going on for multiple decades. It is starting to go into psychiatric direction. It's approved in the US under humanitarian device exemption for obsessive compulsive disorder. There's a little bit, if you have a hammer, everything looks like a nail. It seems to me that every possible behavioral or mental problem is now being explored for treatment through this particular mechanism or technology. The next sort of step in this was to come up with what's being called closed loop or responsive or adaptive or bidirectional DBS. And what this does is it puts one electrode into the brain to gather information that will suggest the need for stimulation, which is then delivered by a different electrode. So or potentially can be done with one electrode. Anyway, there is a bidirectional aspect. We gather information about the need, like the onset of an epileptic seizure, and stimulate on an as-needed basis. This has a whole lot of advantages in terms of battery life, in terms of making sure people don't have side effects of unneeded stimulation, delivered only when it's needed. So it's well suited to episodic fluctuating symptoms. So the next question, what happens next? And so I think there's three big things happening here. First of all, we have a co-evolution of the technology and its applications. If you're able to do this kind of thing on an as-needed basis, you open up a whole range of fluctuating conditions with fluctuating symptoms to be amenable to treatment in this way. So we see this potentially dramatic expansion in target conditions. Another step, however, flows from the difficulty of identifying the biomarkers for particular behavioral and mental conditions. We don't know where in the brain to pick up the signals. So people are now looking at using a whole range of multimodal signals. And this is, I find, absolutely fascinating. They're looking at peripheral biomarkers, so skin conductance, electromyography, nerve signals peripherally, chemical biomarkers in the blood, wearable devices. In Parkinson's, for example, you can have wearable devices that will pick up tremor, freezing, rigidity, gait issues, environmental cues. So there's a lot of people looking at addiction treatment and saying, hey, if we can geolocate you to be presently within a casino, and we know you have a pathological gambling problem, this is information that we add to the algorithm to determine whether you need a little zap to control the behavioral problem. And I'm not making this up. This is the underlying logic of it. And so basically any kind of signal can be built into a model to suggest a need for the intervention at that moment. And it does get a pretty Black Mirror, I have to say. Like when you start working in, I mean, one of the papers, did I cite that one? Yeah, the one up there talks about using facial recognition software embedded somehow in this to detect, to address conditions in which there's a difficulty in interpreting body language and facial signals. So that might be in PTSD, where there's a facial expression that's misinterpreted as aggressive when it's not. In autism, it's well known there's a difficulty in understanding these interpersonal kind of social psychological cues. Could that somehow be identified by software to suggest the need for stimulation at that point? So it becomes clear that we're building a very complex model of many multimodal information inputs. This is a tremendous strength in terms of trying to get the appropriate stimulation for a particular patient under conditions where symptoms vary by individual and also by location and by the whole nature of the stimuli that the person is living within. But you need machine learning to figure this out. This is a lot of stuff. If you want something less crude than always on, always off, or one particular stereotyped response to one particular stereotyped input, you want something that can do better than that. And so the next step is the inclusion, and that's the article at the bottom there is an example, if you'd like to follow up, of starting to use AI methods to do, as it were, reinforcement learning in real time. So there will be a lot of training of the device, but at the same time, if you program it to recognize symptoms that need to be alleviated, and then allow a little bit of space within which the system itself can by trial and error, find out what reduces symptoms within a given environment, you begin to get a more tightly, I should say, personalized, individualized set of tool for a given individual. So, okay, so now what do we make of all this? I want to take a quick break here and bring you to the law. And I want to tell you about the laws of psychosurgery. So we have laws actually in a lot of jurisdictions that regulate surgery for psychiatric, neurosurgery for psychiatric issues. And a colleague and research assistant of mine have done a big 50-state survey in the US to look at the laws. Some really interesting sociology of medicine nuggets in there. In Utah, it's illegal to use psychosurgery to change someone's religious beliefs, for example. Stay tuned for the paper, it's really interesting. So, but if we look at what is common across many Canadian jurisdictions, many Anglo-American, Australia, UK, et cetera, and the US, what unites them all is a concern about the vulnerability of patients, and this flows from the 20th century experience with the lobotomy. It was a reaction to that. And so it tends to take the form of bans of this surgery for certain specific populations because of vulnerability, or to impose additional requirements for oversight, record keeping, and so forth, all with the objective of protecting vulnerable people. Just a quick example from Ontario. Psychosurgery shall not be administered to a person who's incapable of giving or refusing consent on his or her own behalf. In other words, no surrogate consent allowed. You must be capable to get it. Raising, a little digression here, a really important ethical legal dilemma, which is if you have something that's really useful that everybody else can get, but it's only for capable people, you both protect, but you disenfranchise. You harm if it would be useful for them, while you still protect from the inappropriate application. And then I include a quotation from Nutton and colleagues in 2014, World Consensus Guidelines, saying, hey, there are cases of people with often developmental conditions like Lesch-Nyhan syndrome with low IQ and extreme autoaggression problems, where they pull out eyes, bite off tongues, and so forth, and control mechanisms are physical or chemical. And so you might say in those circumstances, do we want this form of protection for this population if we can establish its useful treatment? Okay, so I've said we are already concerned with vulnerability in the context of the kind of psychosurgery we do without AI. But what might AI add to this concern we might have about vulnerability? And I want to take you through a couple of cases of people who have had interesting effects subsequent to DBS for Parkinson's treatment. So in a minority of patients who get dopamine replacement therapies or who get DBS, there's a behavioral patterns which develop. It's a side effect. Impulse control disorders, hypersexuality, hypomania, problems with gambling and shopping. And so there's a kind of disinhibition and compulsive behaviors develop. This can cause problems interpersonally. It can cause problems financially. So you get a shifting in behavior and personality, sometimes in the direction that the changed patient actually welcomes. So here's what I want to talk about: consent and the shifting self when we're talking about intelligent adaptive DBS. So how do we do informed consent? It's hard enough already to tell people about potential personality and behavior changes under normal DBS, but if you have an algorithm that's adaptive, nobody knows how it's going to change, really. We have an even more challenging problem in telling you what might be the side effects that you might face. And here an example of a 62-year-old man in Holland who developed mania, full-on mania with with DBS for Parkinson's, and it was a bit of a problem. He had to be hospitalized. And then what do you do? Well, he was incapable, so the problem of capacity didn't present itself. They turned it off and asked him, what do you prefer? And he said, you know what? I prefer to be able to move. So keep me in the hospital, manic, but moving. And so he was able to be returned to a state of capacity, his time won, as it were, to make that decision for himself. But what do you do if the person is altered but is not rendered incapable, and you have the changed person at time 2 who says, you know what, this is great, I like these symptoms, especially if it's hypomania. And meanwhile, the family's like, what is going on? And if you imagine that guy prior, seeing how he had changed and what's happened to his social relationships, he might also say, whoa, I'm not sure about this bargain. Here, this is a bit of a more interesting problem ethically and legally, because we tend to say any person who's capable gets to make up their mind. So an example to kind of put this into more sort of sharper relief for us, I've got 2 minutes, I'm going to make it. Speaking really quickly, I noticed, sorry. So what do we do? Who should decide for the capable but altered person? And an example, a 33-year-old German man who is reported in the literature as well. Now, he was getting DBS for OCD. He developed euphoria as a side effect. And I've heard of a couple of cases like this where the OCD symptoms are not affected, but there's some sort of affective, emotional change. And the cases I've heard of, the neurosurgeon is often a bit uncomfortable with this. There's a sense that this emotional change is somehow inauthentic, improper, not the target or objective of the medical intervention, and therefore inappropriate. And in this case, the decision was made, we're going to titrate you down, even though the patient was saying, hey, I like this. The doctor said, no, actually, this is too much, down it comes. And so to me, that raises a really interesting question. If it's in your head, who's going to make the decision about those particular symptoms and the mix of symptoms that are to be viewed as pathological or non-pathological? And for me, the metaphysically more challenging and interesting question is, who is reflecting the authentic desires of the individual? Is it the person beforehand and their mix of values and personality characteristics? Or is it the changed person who arguably cares about different things and would actually make a different choice than the first person might? And so what I would like to suggest to you through these examples is that there's a different kind of vulnerability at work here. Everybody is vulnerable. Basically they're vulnerable to their future selves in terms of who gets to decide about the continuity of the person in the first instance. And so I have a little proposed solution, which I'm looking forward to hearing everyone argue afterward, that capable people get to do what they want, people change all the time, there's no problem here, nothing to see here. But a Ulysses agreement, I think, is a useful way for the law to think about this. So we have no problem in the law with contract where we bind our future selves. Totally uncontroversial. However, we don't really allow you to bind your future self to medical decision-making because it's an infringement on bodily integrity. We instead allow the second person to renege as much as they want. A Ulysses agreement or contract would do something differently. It would be an agreement to be enforced against your future capable self to discontinue treatment at specified intervals to allow for reassessment of treatment effects by the original person. And so this would be a paternalistic derogation from the usual principle that people are allowed to decide for themselves if they're capable. But I wonder if it's a response that is worthwhile as we move toward the integration of AI and its unpredictability and its sort of co-production of personality in the neuroprosthetic area. Thank you.
So I guess I'll start talking. So my name is Tiago Mestre. I'm a neurologist and a Parkinson's disease specialist. I work at the Ottawa Hospital. And first I'd like to thank the invitation by Jennifer Chandler. It's definitely a challenge for me, just being a neurologist and being such an illustrious crowd, audience of people in the law field in ethics. And so for my presentation, so this is the title, Clinical and Ethical Aspects of Mobile Health and Artificial Intelligence Parkinson's Care. And this topic will come from a very specific example of a project that's being developed in our group. And it's focusing care for patients with Parkinson's disease. And why? Because, as many of you will know, Parkinson's disease is a chronic condition for which there is no cure. And patients not only have tremors, other motor problems as gait, falls later on the disease, but then they go on to develop cognitive impairment, psychological problems, autonomic problems. So definitely a complex management that really goes beyond the regular training by neurologists. And currently what we offer is seeing patients every 6 to up to 12 months in an outpatient clinic, where a general neurologist or a movement general specialist tries to come up with a plan and recommendations for till the next visit. Unfortunately, the access to community resources is very ill organized and will change from jurisdiction to jurisdiction. But also there's this idea that if the problems are multiple, a multi-specialty care should be attractive and should provide a better care. And what's the impact of Parkinson's disease in the society at large? So these are some figures from Stats Canada, where, for example, the costs related with Parkinson's can go as high as 600 million, and this is 2011, so likely now higher. And it's also a cost for the family. So see, out-of-pocket costs for care partners could be as high as $214 million, per capita cost $25,000 per year. In Europe, it's pretty much the same, so it's one of the top 10 most costly brain disorders. And if you look at the future, we're looking at doubling the incidence of Parkinson's disease 2030, so not that far. And so how can we meet these needs with services by the society, by the healthcare system, in a way that's, I would say, ethical? And so our small contribution to this, we like to think that way, it's coming up with this integrated Parkinson's care network, where we try to shift the care of Parkinson's disease from this model very focused in an outpatient clinic to a home-based and a community-centered care. And right off the bat, that has already some questions. So is this possible in Ottawa? Is this possible in other jurisdictions, not only in Canada, North America, in other geographies of the world? And in this integrated Parkinson's care network that we call IPCN, these are the core values. So bringing the multi-specialty care dimension in integrated fashion. So, and that's the idea of the network. So within a certain jurisdiction, we try to optimize, first identify the resources and optimize the communication between the resources to ultimately benefit patients. But also, and that's perhaps the most important from an ethical perspective, we propose patients to take greater ownership of their disease and of the management of the Parkinson's disease symptoms. And in some societies that might be attractive, but in others might not be and might be difficult to achieve. And so in that relates with this personalized care, so try to tailor our approach to the individual needs of the patients, but also providing education to the patients and care partners so that they know more about the disease and they know how to manage the symptoms by themselves. We bring the dimension of technology to this model as an enabling tool that not only, and it's enabling because it's accessible to patients and should be usable by patients, but also really frees from the ties of a given geography in terms of caring for Parkinson's disease. So easily you can think of bringing these ideas to other geographies where, for example, there's not a PD tertiary care center. But because I've already listed some of these questions, we also brought the dimension of co-design. And so, and I think this is pretty innovative, at least within the Parkinson's disease field, is that bringing stakeholders' perspectives and mainly patients, care partners to shape these ideas. And so, for example, in this project, we have from day one, from its inception, a patient and care partner advisory board that provides from the beginning ideas, their thoughts about, is this something attractive? How should we implement it? And as we go on a research program testing these same ideas, also have them provide the feedback on how to interpret the results, what will be the next steps. And so this is just an example of something we've done back in 2016, where we asked patients within our Parkinson's clinic what they thought about this idea of self-management. In the literature, this calls activation, so how much patients are willing to or are ready to manage themselves. And so the results were actually interesting. So the majority of the patients at least found that to be an attractive idea. And then if you ask them what's good care, and so it's interesting because they don't mention to have a cure for Parkinson's disease, to have the most recent medication that could change dramatically their diseases. So they talk about communication, about integrating the different healthcare professionals into this very focused approach of caring for Parkinson's disease. And then, there's a laser? No. Okay. And then you also ask, how can we better support, so that role of self-management support, how could better support your living with Parkinson's disease? And so they mentioned, improved goal setting and a better follow-up. In the sense that was encouraging to us because we think, or would like to think, that met our value proposition in terms of the IPCN. But then focus more into the topic of today's conference. So what is the role of technology in Parkinson's disease care? And this is not restricted only with mobile health and artificial intelligence. In a nutshell, we can say that's not if it's possible, but really how. How are we going to achieve it? Again, with that idea that it's definitely easy to come up with a product, but how are we able to give value to that product in the sense that any patient can actually use it and can identify the value of using that product. So these are some approaches that are ongoing in Parkinson's disease, mostly for this purpose of online health tracking. So tracking symptoms, either motor, non-motor, and so it could be from wearable devices that provide the continuous monitoring of data. It could be, for example, through a smartphone that asks the patient to do specific tasks, and that will provide an impression on how the patient is doing from a motor perspective, for example. But also it could be, home monitoring. For example, prevention of falls, identifying situations where patients are at higher risk of falling. I will not talk about deep brain stimulation because that's a whole different field. And so there's these issues that I've listed, and I'm sure that you've already touched some of these aspects today and yesterday. So the aspect of, do we really need to have a continuous monitoring? Not only from an aspect of, do we need that data to make a clinical decision, but from an ethical perspective, how ethical is it to continuous monitoring a patient 24 hours, 7 days a week, and ultimately, what's the value of that? And then also I would emphasize this aspect of, ultimately, if you're collecting this amount of data, who actually owns the data, and how do we do the data sharing? And that's, I think, has implication not only from an ethical perspective, but as we go on to developing our own project, it does even have implications in terms of research and development of all these tools. So again, not if, but how we develop this. One example that I like to give is, this is published in the JAMA Neurology, which is a high-impact journal within neurology. And so these investigators based in Rochester and Johns Hopkins, so they use smartphones and machine learning to try to come up with a scale that allows to define how severe a patient is in terms of his or her Parkinson's. This is very attractive because patients can basically contribute actively to collect this data. They can use that data for themselves. They can share it with the physician. And this has implications not only from a clinical practice perspective, but also from a research perspective. For example, collecting data at a far geographic distance, for example, in clinical trials, enabling patients to take part in clinical trials where all of a sudden the geographic distance is no longer relevant. But in the limitations section, you see this comment. So first, the patients that actually took part in the trial, they were white, college-educated, people who own Android smartphones. And so actually, so only 51%, so half of the people that downloaded the application were actually met the criteria to enter in the study. And that means that they actually were able to use the application. So that really defeats the purpose of why we are developing these tools, at least the way I like to think it. And so in collaboration with the School of Communication, Will Sylvie Grosjean and Luc Bonneville, we're trying to kind of start making a review of how can we make or develop these tools in a social conscious way that actually can be used by patients in the society at large. And so they've made a review of the main barriers to using tech. And so these are some aspects that I've already mentioned. So the ease to use, ease of use or usability, aspects of to which type of patients does it apply, both in terms of the stage of the disease, but also the socioeconomic status that this paper, unfortunately, is a good example of. And so, in our small contribution, we tried to come up with this digital health platform. It's a patient portal that patients can use, again, primarily to manage themselves and living with Parkinson's disease, but of course having this element that they can share that data, for example, with healthcare professionals, not only us, PD doctors, but also physiotherapists if possible, and I would say also, for example, general practitioners. And our idea is that this is kind of the main platform, and in the future we're able to add other modules that, for example, wearable devices, speech therapy, apps, or even exercise monitoring. Again, we are using this same idea of co-design, and so from the beginning, as we developed the first mock-ups of how this platform could look like, we tried to have patient input. So in these participatory design workshops, and the summary of this slide is that this is a very helpful step, not only for us as researchers in making a findable solution that's actually usable, but I think that also has an ethical value to it. And so my last slide is to share with you an interesting project that basically tries to multiply the issue of developing an integrated care model in Parkinson's disease that use technology, multiplied by 7. So it's mostly a European project. We are the lead partner and involves countries such as Portugal, Italy, France, Germany, Czech Republic, and Ireland, and in which Jennifer Chandler is taking part. And so we're trying to bring this dimension of the social dimension of caring for patients in Parkinson's disease. It could be with any other neurodegenerative disorder or chronic disorder. And so we're looking at not only a development of the care model that I presented to you today, but also what are the health economy implications, looking at health geography, so by what we call spatial analysis, looking what are, for a given geography, what would be the limitations in terms of availability of resources to implement such model. Then a specific module of developing technology and also developing outcome measures that capture better the impact of an intervention in the whole life of a patient. And for that, recognizing the importance of ethical and legal issues, we have this cross-cutting group led by Jennifer Chandler and the German counterpart Christian Wuppen. And these are some ideas that they are starting to look at. So in terms of the integrated care model, what are the implications of decentralizing the care from outpatient clinic to the home in the community, the aspect of bringing technology, how does that change patient-physician relationship? Is it good? Is it bad? Can we find the best way to develop it? And this kind of, that was, these slides, by the way, were shared by one of the members of this cross-cutting group, Bjorn Schmidt-Loon. So it's not my own ideas, but certainly I share them. And also this aspect of uncocooning. So what's the implications of all of a sudden this information can be widely shareable, not only patient, family, but healthcare team. And from a technology-specific perspective, so monitorization aspects, data collection, data safety and security, and also so what happens when there's an error? And again, This will be certainly an interesting challenge because we're not only looking at North American or Canadian law, European law, and then multiplied by the different countries in Europe. And with these kind of ideas, I hope I have generated some questions in your minds. And really it's what we are proposing, so that the development of technology, it takes in consideration all these stakeholders. So healthcare system, patients, physicians, the developers, and ultimately healthcare systems, so the providers or the financiers of these solutions, because ultimately we would like to implement these ideas in a healthcare system, so that affects and impacts on the society. And thank you for listening to me.
My name's Adam Sachs. Oh, is this on? Easy. My name's Adam Sachs. I'm a neurosurgeon at the Ottawa Hospital. And my clinical practice involves placing deep brain stimulation electrodes. From a research perspective, I focus on brain-computer interfaces in monkeys and in the very near future in humans. A brain-computer interface is a system that extracts signals from the brain in real time to use them for various different purposes. One potential purpose is to replace lost function. A second purpose is more like a neurorehabilitation from stroke to restore function. And there are a variety of other potential purposes, including neurogaming. And there are different ways that signals can be extracted from the brain, and they range in how invasive they are. And as a general rule, the less invasive have a higher signal-to-noise ratio and therefore produce a less reliable signal and less reliable control. Well, I'm a neurosurgeon, and so I don't really do non-invasive. So our trial will be the most invasive, which will be implanted arrays of microelectrodes in the cortex. The system that we have, we were able to purchase because of a Canadian Foundation for Innovation grant, and it involves extracting signals as well as the arrays, processing the signals, and then producing something that can be used. It could be a virtual reality model, it could be a computer keyboard or a robotic arm. So the name of the trial that we have that we're currently recruiting for is the Neurocognitive Communicator, because we're attempting to use cognitive signals, not just motor signals. And we applied for the REB in January of 2017, and therefore we call it the NCC 1701 trial. And that is the only reason that we named it NCC 1701. So just to go over, clinical research takes a long time. We were awarded the grant through which we were able to purchase the equipment in 2015, and only now are we in the recruitment phase, and we haven't done the surgery yet. The purpose of the trial is to test participants who have high cervical spinal cord injury and have very little use of their limbs, or ALS, and also do not have upper or lower limb weakness, and to provide them with an assistive device and test the bounds of what that assistive device can do. And so we look at utility and ability as a kind of theoretical plot, with the more utility that you're able to get from a device or a non-invasive BCI correlates with how much ability you have. But we have patients with very little ability or locked in. If they've got a brainstem stroke, they have no movements. Currently, there's nothing that can help these patients. And so invasive BCIs attempt to occupy the space with the most disabled patients being able to get a little bit more utility of their assistive device. This is the size of the array that we're using. It's the Utah array, or previously called the Utah array. It consists of, in our case, 2 arrays of 64 microelectrodes, each 1 to 1.5 millimeters in length, and 100 gold wires that then transduce those microsignals to a amplifier and a digital processor, and then a computer system that decodes them. I hope none of you are squeamish. My videos, okay, maybe my videos don't work. At any rate, is it possible to see if you can run the video? Maybe that, oh, there we go. Thanks. So this is a surgery that I did on a monkey, I don't know how long ago. Well, maybe that the videos didn't turn out, maybe your lucky day. So this is an array implant that I did a while back in a monkey. At any rate, looks like we're out of luck. And these are the signals that we get from the brain of either a monkey or a person when we're implanting them. So the question is, how do you take a sequence of action potentials and convert them into something that's usable? And there are different strategies. Broadly speaking, there's a strategy of using linear. So there's different ways to look at it. One is that we can try to do discrete decodes, where I try to decode, one of 8 directions, or one of 4 or 5 different objects, or a letter on a keyboard, or a continuous decode. Another way to look at the decoding algorithms is that they can be either a linear decode, where you take the neural space of all of the electrodes and you create a point in some higher dimensional coordinate system, and you can train it under various conditions and create this clusters, and then find the hyperplane that best determines what side of the cluster you're on. That's a classic linear decoder. A second way of decoding it is to use neural networks and perhaps machine learning and deep learning to determine what the intent is. Of course, you still need training data. In fact, you need lots of it. But the decisions and the features that are extracted are not as clear to the user or the engineers that are generating the decoding algorithms. And we intend to use both classes of decoding algorithms in our trial. So probably the first, maybe we'll just give this a shot with the video. Probably if the first one didn't work, this one won't work either, but pardon me? Yes. All right, well, these are 2 videos that show the state of brain-computer interfaces. Although the videos are a little bit old, the state of affairs hasn't changed very much. And I showed the videos together because the one on the top left is from the BrainGate trial. The one on the bottom right is from the Pittsburgh trial. And both have participants who are severely disabled. And the one on the top left, she's using a robotic arm to drink cappuccino on her own for the first time in 8 years. I think the patient has ALS. The one on the bottom left, it's a patient with spinal cord injury eating a chocolate bar. And I timed them so that they're racing. But at any rate, what you can see is it's amazing that people are able to control robotic arms. There's also an engineer in the background with a hand on the stop the robot from hitting the disabled person button, and the robot is slow. So a lot of areas for improvement. If this is going to actually be useful, you cannot have an engineer on standby, and it needs to be more effective and more usable by the user. And it can also be used to control computer keyboards. And the group at Stanford recently, I think, got to the point of typing at 8 words a minute, which is pretty amazing if you consider what somebody with locked-in syndrome is otherwise able to communicate. And so we are intending to implant the arrays in the premotor cortex in addition to motor cortex. And so we're trying to occupy a space of even more utility in severely disabled participants. And so we consider these to be combined cognitive and motor neuroprosthetics. So if a motor neuroprosthetic controls the moment-to-moment kinematics of a robotic arm or a computer cursor, a cognitive neuroprosthetic makes decisions or extracts the decisions and the desires and may integrate either with a motor cortex BCI or with some other kind of robotic system. So in the monkeys, this is area 8AV. It's the same area in people. And this is an area of the brain that is involved, as I mentioned, in decision-making, in attention, in covert attention, in working memory. So lots of features that are easy to say but really represent who we are as people, the decisions that we make, our desires, our choices, our intelligence are all embedded in this area of the brain that we're implanting an array in. And so this is just some data from a publication that we had from monkeys showing that we could decode in many cases with very high percentage the decision that a monkey was about to make. And that worked across a variety of different algorithms. So I identified in the next few slides some potentially ethical areas that require consideration. And I think if you really sit on this and think on this, there's a mind to be explored. But the first one, as Jen was mentioning, is the issue of a vulnerable population. So people who have a spinal cord injury or ALS are very vulnerable, not just physically vulnerable, but emotionally vulnerable. They're desperate. So they want anything. I know patients who have gone to China or India and pay tens of thousands of dollars to have their stem cells injected into their spinal cord when these treatments are not available in North America because the data are insufficient to suggest that there's value in it. But they're desperate. You can't move, you're desperate. And so we have to treat that desperation with respect. And at the same time, the technology is changing over time. So how do you consent a patient or participant in a study or a patient in a treatment when the patient is vulnerable and doesn't understand the treatment and the user, the provider, also doesn't understand the technology or the value of the technology? How can two people who don't know what we're dealing with come to any agreement on what we're getting into? I think that is a challenge. So, we tell participants in this trial, at this stage, it's actually simple because we tell them you're not going to get any utility out of it other than the fact that you are have a purpose, you're a member of a team that is working towards a research goal, but don't think that all of a sudden you're going to be emailing your friends and surfing the net and feeding yourself with robots because this is a research program. Right. So I mentioned conflict of interest just because I have a personal interest in the word conflict of interest. We all think if you don't have disclosures, you don't have a conflict of interest. I think in a way, everybody who's invested in a research program, maybe their livelihood, their ambitions are embedded in it, have a conflict. We're all conflicted in some way, and so there are conflicts even if there's no remuneration involved. I mentioned that prefrontal cortex creates decisions, and we want to extract decisions. So this needs a bit of unpacking. What is a decision? From the point of view of a behavioralist or a psychophysicist, a decision is an output. So if I create a perceptual paradigm in a person or a lower animal, where if I can see, let's say, dots moving in a certain direction, I hit one keyboard or one button, or I hit another if it's moving in another direction. That's a very simple decision. That's just a perceptual output. But there are obviously higher order decisions. We make decisions all the time, and they're based on our personal preferences, our choices, our ethical boundaries, our histories, our personal conditions. And so it's not quite straightforward for us to understand what we're trying to extract. And more importantly, if there are mistakes in extracting decisions, our decisions are linked to our perceptions of ourself, and mistakes could also impact that self-perception and the relationships with others. So I see two potential sources of error going forward with this. One is what I call a neural sampling error, and the other is a decoding error. And I don't, there's maybe somewhat artificial boundaries, but it's a way that I've thought about this. From the neural sampling perspective, as scientists in general, when you conduct an experiment, you have an environment. That environment is consistent. You provide an input, an experimental variable, and you look at the output. That's how science works. In order for it to work, the environment needs to be controlled. Well, it's easy to control environment in a test tube. But in the human brain, where you're looking in prefrontal cortex of one of the most complex and personal areas of the brain, how do we know what small issues might be affecting dramatically the behavior of the very puny region of neurons that we're sampling? So it may be that what we test our algorithms on may be vastly different from what's happening in reality, and therefore we decode the wrong decision or the wrong intent. Another issue is part of decision-making is choice. So if I have a choice, I consider both potential choices and then decide one or the other. I may make one area of my brain might be thinking about the choice that I countermand as a human being. But if we're subsampling, we may choose the wrong choice, the wrong decision, the one that's countermanded, even though it's being considered. So from decoding, I imagined a few experiments that I envision. One is a hybrid system where the user's wearing an a virtual reality goggles, and there's a camera. The camera scans the environment, and an artificial intelligence algorithm segments certain objects. And then the person's prefrontal cortex decodes which object they're interested in. Okay. So what if there's a problem with the decoding algorithm? What if I misclassify a bottle of beer and a bottle of poison? I may decode the brain correctly. I'm interested in the bottle of beer. But if the AI algorithm misclassifies them, that's a serious problem. And then neural intent may also be misclassified, as I was mentioning. And I think that another problem is that it may correctly classify before the user's made the decision. So how would you feel if I'm able to predict a decision that you're about to make? Let's say you need to make a decision about a job or a potential friendship. And I'm able to predict and communicate to you the decision you're going to make before you made it. That could have a serious impact on our sense of autonomy, even if we're doing the correct decodes. So in conclusion, I think BCIs, brain-computer interfaces, are an exciting new neurotechnology in the research realm. We are currently recruiting for the NCC 1701 trial, and I think that ethical issues at very minimum center around the difficulty to consent and decision decoding errors from neural subsampling or problems with the AI decoder itself. Thank you.
So thank you for those wonderful presentations. We have some time for questions. We started about 10 minutes late, so we'll take another 10 minutes. And just reflecting on that last presentation and the end of the last panel talking about nudging, one wonders how not just predicting decisions, but actually influencing those decisions through these kinds of brain-computer interfaces could actually be challenging autonomy and agency in much more complex ways than we've experienced before. So I think we have a question there.
So this is really interesting because my background's actually in neuroscience, so it's very exciting. And one of the things that was kind of an axiom that ran around our department was we understand more about space than we do about the brain. And so when I'm thinking about some of these things, when you start going down on all these levels, you really start to see, and I think Dr. Sachs, you were pointing to this very helpfully in thinking about it. And so one of the things that I've noticed is that some of the applications that seems to be working quite well, such as in Parkinson's, have very discrete areas of the brain that are affected, and we know this pretty well. Whereas when we extend this to other areas of psychiatry, such as bipolar disorder, psychotic disorders, we even for the past 50 years, we have yet to find a biomarker and even understanding what that biomarker looks like. So I'm wondering if you can kind of comment on, when we're talking about regulation, what kinds of things should we be looking to regarding neurotechnologies and some of those areas where there's fuzzier boundaries between how well we know what we're actually looking at.
Right. So, thank you. You touched on a few points, and I think potentially other panel members might have some input. The deep brain stimulation, you're applying electrical stimulation to the brain, and brain-computer interface, you're extracting the electrical signals from the brain. You were mentioning, I think, the boundaries of deep brain stimulation, and you know what we should explore and how we explore it. So I don't know that we need to entirely understand the mechanisms in order to approve an indication. So that's in some ways a bold statement, but we don't entirely understand how DBS works. There's many drugs that we don't understand how they work, and yet they're approved. And so I don't think that understanding the underlying science is completely is a necessary prerequisite, although I do agree that having a theory and perhaps some animal models that validate the theory is necessary. So then the second question is, the second part of that is, how effective does it need to be? So with depression, that's something that's being explored. Different areas are being looked at, and there's probably different phenotypes of depression that respond to different areas of stimulation. People that are severely depressed, that nothing's worked, they're on multiple antidepressants, ECT has failed. Those are the people that are being currently considered. I don't have expertise or experience in that area, but I do go to the meetings, and I've seen this discussed a number of times. And I think there's a reason that it's not clinically accepted. I don't know how invasive something is correlates with how much risk we're willing to accept. So if there's a stimulator that's placed under the skin, then I personally would accept a success rate of 50%. But for a deep brain stimulator, I think you need to have a higher level of success and a better risk profile to justify its use. I don't know if that answers the question, but I think there are a number of different issues around expanding deep brain stimulation indications.
More questions? So I have a question, since there's nobody at the mics. I was really appreciated seeing the Ulysses contracts, and philosophers have talked about these Ulysses problems and ethics before. But I wonder if you've also thought about or see any potential application for the kinds of systems they use for administering painkillers and opioids, where the patient gets a button and they can press the button as much as they want. Initially it's full dosages, but then it decreases, and there's an algorithm and a machine that's deciding how much dosing might be necessary. And would there be an AI application there, and how would we try to prescribe that?
This is such a great question. This is a whole topic I wanted to put in my presentation, but no space. So I did. This is not a plant, by the way, but I'm getting. So there's a whole, within the evolution of closed-loop DBS, there is a kind of a closed-loop BCI hybrid application with the idea that the system will learn to pick up the patient's voluntary modulation of brain activity, so that the patient can kind of think, now I want the stimulation to start, now I want it to stop, without having to mess around with the controller or buttons or turn on or off, but by thought, basically titrate up and down the stimulation. And it's discussed in particular in Parkinson's, where you can have a trade-off. The stimulation can allow movement to be improved, but degrade speech.
I can't resist. I don't know if I was in high school or an undergraduate, I saw a video of a mouse that had just a single electrode implanted in its brain, and it could push a bar and get a jolt and feel presumably pleasure, because the mouse went wild and just kept pushing. So I'm led to the question, which may be beyond our remit in this room, but is there something, where do we draw the line between medical use of DBS and recreational use.
Well, it's pretty, it's pretty expensive and risky, so I doubt we're going to really get into widespread retail use of DBS. I think that much more likely is people, and this exists online, you can go and get the specs yourself, which I don't recommend. I bet they won't recommend it either, to build your own brain stimulator with 9-volt batteries and a cap and some electrodes and things for surface stimulation. So right now, the various surface stimulation technologies that exist, they only sort of go a sort of a limited depth into the tissue, but there's, and this is moving, it might, I don't know if it will put neurosurgeons out of business, because there are forms of non-invasive deep brain stimulation through electrical field interference and so forth. I think that the ultrasound and gamma knife still remains your purview. Maybe the field interference technique would be as well. But if these kinds of techniques work well, are cheap, have a good safety profile, you can imagine the use of all these things potentially expanding dramatically.
I would just add that even for patients, and as a disclosure, so both I and Adam, we work together in the DBS program in the Ottawa Hospital, and I would say as the technological advances of closed loop DBS, wireless control of programmers, I can envision some cases in the future where actually patients that have the necessary expertise, and they had it for medical indications, the DBS, but they could feel tempted, and perhaps it's easier to assume control of that specific treatment.
So we don't have any more questions, but maybe we'll just get a 1 minute or so wrap up from each of our panelists and then take a coffee break. Does that sound reasonable? Do you want to?
Oh no, me first. So I think for me in this area, the thing that I worry about a couple of things. One, I worry that the baggage of these treatments that derives mostly from the 20th century lobotomy might impede the development of really useful treatments for patients who have very poor options. And I have ringing in my ears, the same thing was said back at the time of the lobotomy. This is really going to help people who have no good options. So there's a little bit, history repeats itself, but I do think that these look substantially different in terms of their sophistication to the ones we had in the past. There's a lot of ethical sensitivity. I think what would be really important is to make sure society is brought along with, understands what's being done with these, sees sort of the safety and benefit and risk profile with clear eyes, so as not to derail a promising line of work. That being said, I do find these metaphysical issues fascinating. I think we are at a point with the development of these technologies where we're not going to sort out the consciousness mystery, but we're going to be able to learn tremendous amount about ourselves, and I think there's really important societal ideological work to be done to integrate this information in the coming years.
In terms of the aspects that I covered in my presentation, I think as we embarked in developing this care delivery model and bringing technology, there's always the ultimate vision that it's how can we bring it to, as I mentioned, to a healthcare system, to society, and so if we start thinking that way instead of just our own center, our own time and space, it becomes more complex, and the ethical policy aspects become ingrained in our research development program, and also, as I mentioned, bringing patients, care partners, and ultimately end users to the development of this research project, which is something that normally we would not do, but it's definitely a movement and it's a trend. And I find that these aspects, like this type of intervention that we know as complex interventions, because they really can, not just a drug we're giving is not a lead we're implanting in a patient's brain. It's actually something that has an impact in an entire region, in a society. So it really brings a lot of value to developing, I would say, more usable, more successful, and ultimately more ethical interventions.
One of the points that I want to make is that when we consider neurotechnologies, is this on? When we consider neurotechnologies, I think we have to consider the brain itself and the unique physiological properties of different brain regions. So deep brain stimulation can make people hypomanic because the anterior area of the subthalamic nucleus is a limbic area and is involved in limbic and emotional circuitry. And similarly, other areas of the brain may not be involved in limbic or cognitive areas, are probably fairly safe to consider either stimulating or extracting signals from. The prefrontal cortex is a very late evolutionary area and is intricately related to our humanity, and it raises specific concerns and specific ethical challenges. So I think when we think about neurotechnology, ethics is intricately linked with the physiology of the brain area as we understand it, and that is a special consideration in addition to all of the typical considerations of new technologies and vulnerable populations.
So please join me in thanking our panelists.